Hi guys, welcome to my YouTube channel. I am Denmark Aranas, a postgraduate medical intern, and I basically provide informative videos to medical students. And also, I would like to give aspiring Filipino physicians an idea of what a medical student usually tackles in med school. If you find these videos helpful, please don't forget to hit the like button and subscribe and click the notification bell to be updated for my new videos every week. Today, I will be lecturing about the overview of adult history taking. One vital trait of a good physician is being able to take a good history and PE. In med school, they have been stressing it out that we must never rely on laboratory examinations to arrive at a certain diagnosis. Instead, we must be able to formulate our impression already from history and PE alone. And then, that would hint us about the possible diagnosis of a patient. Laboratories are just confirmatory of what we have formulated. So this topic should be instilled in your hearts and soul and minds. Do your very best to understand well the techniques for taking history. And also, I provided in this channel a lecture and demo of PE for an adult. After this video, please watch those too. All first year med students should make it a priority to develop skills of history taking and PE. Okay, here's the topic outline for this discussion. I will be defining first what health history taking is and then tell you its purpose. Next, I will inform you of the two types of patient assessment and then I will be teaching you the techniques of skilled interviewing. From there, I will be showing you the proper sequence of conducting the interview. And then lastly, we will go through the components of adult history taking. Okay, let's start. Health history taking is defined as its goal of catering to the well-being of the patient. And it has two forms, the patient-centered and the clinician-centered history taking. Let us further differentiate the two. Patient-centered history taking involves the use of non-focusing skills. And in here, we allow our patients to freely express themselves. While clinician-centered history taking involves the opposite, where we are the ones who guide the patient in what details they provide. Guided questions we provide are answerable by either yes or no, very opposite the patient-centered questions, where patients could attach emotional cues to what they express. Here, I would like to emphasize that we utilize both forms of health history taking. We start with the patient-centered skills, and then at the middle, we go to the clinician-centered approach. This way, we extract the biopsychosocial story of the patient's condition. What now are the purposes of history taking? Well, it's threefold. First, we establish rapport to our patient and to ensure trusting and supportive patient to clinician relationship. Then, we could easily gather information, and after that, with our patient, being able to establish the good relationship, that he or she will not have any inhibitions from sharing. Then in our part, we would offer information that they need based on what we have extracted from the history. Let's now go to the two types of patient assessment. So we could do history and PE, either comprehensive or focused. A comprehensive assessment is generally for new clinic or hospital patients. This provides fundamental and personalized knowledge of the patient's case. Doing a comprehensive assessment strengthens the clinician-patient relationship because it encourages openness and mutual trust that are both expressed by the two. And of course, doing a comprehensive assessment repeatedly develops the skills of the clinician. Well, focus assessment is more appropriate for established or previous patients who come only for routine or even urgent care visits. It addresses focused concerns or symptoms. Here's a list of techniques we doctors employ as skilled interviewers. A general premise would be the interview questions should always start from general to specific. Then a rule of thumb in questioning is to always observe questioning one at a time. Sometimes you must help your patients in expressing themselves, like when you ask them about the description of their pain. If they cannot seem to find the words to describe it, give them options of descriptions that would fit what they are experiencing. Then, never be lazy in clarifying unclear points that your patients are expressing. Nonverbal communications is very important. Okay? Pay close attention to eye contact, facial expression, posture, and others. These are clues to the truthfulness of the patient's declared condition. Empathic responses is about doctors being sensitive to the patient's feelings. We should not be like robots in engaging with our patients. Always show that you care about their feelings. Inquire about how they feel and then respond with understanding and acceptance. Then we validate. We validate the patient's emotional experience by telling, I understand, or yes, that sounds really upsetting. After that, we must provide reassurance. However, we must avoid premature or false reassurance. As doctors, we must always express our desire to have a committed and continued partnership with our patients, regardless of what may happen in their disease. Tell them that you will be with them in their journey of healing, no matter what the outcome will be. And then it's important to give a summary of what you have extracted from the patient. This way, the patient will know that you have been listening carefully and that you have an organized clinical reasoning in mind for the patient's case. Lastly, as physicians, we must always empower our patients to take care of themselves and make them feel confident about our medical advice by making them understand well our clinical reasoning and always share information generously that would help them be enlightened about their condition. When you observe all of these techniques, history taking will be complete and reliable. Here now is the sequence of history taking. We start from establishing rapport, then defining the agenda of the interview to the patient. Next, we allow the patient to share through asking open-ended questions. If we encounter unclear data, then we clarify. When we have all the necessary data extracted, we then generate and test diagnostic hypothesis we have in mind. From there, we make the patient understand the clinical reasoning for his or her problem. Then we propose a plan with the patient. Lastly, we plan for follow-up. And as for closing, we give comprehensive patient education to the patient and empower them that they can manage their disease with your help. Here now are the adult history components. We'll go through each one by one. For general data, these are identifying data of the patient. We follow now the Data Privacy Act. So when we write the name, we only use initials of the patient. For birthdays, we just put the year. And as for the address, we only state the street or barangay. As for the informant, it is usually the patient, his or herself. But sometimes it could also be a family member or any third party that they know. The reliability is about the quality of information extracted from the patient. As a rule of thumb, there is really no 100% percentage reliability because there will always be some extent of ambiguity in the patient's statements and that there may be conflicting other data. And this may be due to patients' poor memory, lack of trust, or even indifferent mood. Next is the chief complaint. This is one or more symptoms or concerns causing the patient to seek care. In my channel, I have a section about the different common chief complaints of patients. You could also check that out to be oriented about the proper approach to each of them. I guided viewers of the right questioning and the possible PE maneuvers that you could employ in the differentials for these chief complaints. As for the HPI, you must always remember the mnemonic OPQRST. Okay, that is a classic basic medical knowledge we must all know. Okay, O is for onset. This is when the patient noted to begin experiencing the symptoms of his or her illness. And you must also take note the chronology or temporal occurrence of signs and symptoms of the patient. P is for precipitating factors. These are the possible triggers of the patient's condition. P could also mean position, and that is where we locate the areas affected in the patient. Q is for quality. We ask the patient to describe what they are feeling. What is it like? For example, for headache, is it throbbing, pulsating, or tension-like? This will help in determining the possible differential diagnosis of the patient's headache. Aside for quality, we also check Q for quantity in terms of pain severity from grading of 1 to 10, 1 being the lowest and 10 being the highest. We also quantify the number of episodes of vomiting and diarrhea because this can support the manifested dehydration of the patient. Next are for radiation, which means aside from the located area of affected, if there are other areas associated to be affected as well. Like when patient is having a chest pain, they also have a jaw pain, and that may indicate a cardiac disease. As for the relieving factors, this could be medications like when patient took pain relievers for their pain that help alleviate the pain. And if the patient took a drug, we must ask the way how they administered it, from dosage and to the effect of the drug to them. As for T, it is for timing, duration, and frequency, when they do experience more than symptoms, and for how long. And lastly, we also ask for other associated symptoms for this, which would help us rule in or rule out differentials we have in mind. In the past medical history, we ask for childhood illnesses that the patient already had. As for adult diseases, we categorize it to four. If they were admitted in the hospital due to medical, surgical, obstetric or gynecologic, and even psychiatric diseases, or if they were diagnosed with certain disease from these categories. We also ask for the health maintenance practices of the patient, like adult immunization and screening tests that they had. Here we also ask for any recent lab tests done and if they have the results with them. Lastly, we also ask if they have any allergies to food or drugs. As for female patients, we also ask for the OB/GYN history, especially when it is related to the chief complaint. LMP means last menstrual period. This is the first day of the previous menstrual cycle of the patient. For the OB score, gravida means the number of pregnancies regardless of the outcome. And as for parity, this is the number of pregnancies that have an outcome of 24 weeks or more. 24 weeks or more is the viable gestational age. And parity includes also live births and stillbirths. Okay, gravida doesn't have any conditions. Any pregnancies should be counted as gravida. Well, for parity, you have to check if the pregnancy uh, reached the age of viability, which is 24 weeks or more. And then aside from the OB score, we also have a mnemonic, the TIPAL. T for term, P for preterm, A abortion, and L for living. Term births are those from 37 to 41 weeks age of the gestation, while preterm births are from 20 to 36 weeks AOG. Okay. As for menstrual history, remember the mnemonic MIDAS, which stands for menarche, the age the patient started menstruating, interval, duration, amount, and associated symptoms like dysmenorrhea. Okay, so for menstrual history, the mnemonic is MIDAS. Okay, don't forget that. Well, for the sexual history, we ask the use of family planning method, and we also ask the last sexual contact, the number of sex partners, age of menopause, and if the patient underwent any pap smear before. Next is the family history. Here we ask about heredofamilial diseases present in the family, like hypertension, cancer, kidney diseases, and coronary artery disease, and others. We also take note the age and cause of death of siblings, parents, and grandparents. Okay. As for the personal and social history, we ask the risk factors that are predisposing the patient to having the disease. And two most important risk factors are smoking and alcohol drinking. For smoking, we ask for how many sticks per day the patient smokes and the years of smoking they have been smoking. With that, we can compute for the pack years. Pack years is computed by multiplying the number of pack per day to the number of years of smoking. Packs per day is computed by dividing the number of sticks per day to 20. So example, a patient has a 10 sticks per day smoking for 6 years. So that is equivalent to 3 pack years. Okay? Remember that. Other data we ask are the following: the type of alcohol beverage, amount and frequency per week, the source of drinking water, garbage disposal, the type of toilet, flush type or manual, and an important factor is the history of travel. This is special nowadays from our current situation of global pandemic. We should always ask about the history of travel for possible infection that they might have acquired from the travel history. And then exposure to endemic diseases, the dietary preferences of the patient, and active or sedentary lifestyle. So all of these are important risk factors that we should consider in history taking. And lastly, we ask about the review of systems to document the presence or absence of common symptoms related to each major body system. And this is the checklist for it. Take note, you don't have to ask all of this. You just have to choose the important pertinent symptoms to consider in order to rule in or out the differential diagnosis in your mind. Remember, everything that you ask should have a basis. Don't go out there bombarding the patient with random questions without any justification or basis. So, really think before asking anything if it is relevant, because that is a common mistake for first time history takers. So, I advise to practice doing history, and the best way for you to practice is by joining medical missions, where you will have a lot of patient encounters. There, you could also practice doing PE. So it is really a must for med students to be able to experience going on a medical mission. Well, that's it. That is all for our overview of history taking. I would like to leave you with this message. As a graduate of Batch 2020, St. Louis University School of Medicine, I pledge to continue believing in the goodness of life, people, and the world, and most especially in the goodness of our Lord Jesus Christ. Through him, I was able to surpass all the trials of medical school. I also pledge to turn my dreams into reality. Someday, I will come back as an internist specializing in pulmonology, and I will be a teacher in my alma mater. Thank you for watching my videos. I hope I was able to help you even in a small way. God bless and have a good day.